do welcome you, and we're very pleased that you've joined us. There are no rules to speak of tonight except to please put your phones on vibrate or turn them off. Other than that, we're here together to learn together. Let me tell you a little bit about our speakers this evening. When I spoke about our new members, the first one I'd like to introduce is Dr. Edgar Staren. And Dr. Staren is a general surgical oncologist and a breast surgeon, and he's just joined us at Eisenhower, and we are very, very excited to welcome him. Most recently, he was Chief of Operations and Director of Breast Cancer Surgery for Arizona Oncology, and prior to that, he served as Professor of Surgery, Vice President and Executive Director for Cancer Services at Wake Forest University Baptist Medical Center. He's a graduate of Loyola University, Stritch, thank you, School of Medicine, and received his general surgery training and surgical oncology fellowship at the prestigious Rush University Medical Center in Cook County. He holds a PhD. You want to be impressed? He holds a PhD in immunology and microbiology from Rush, and where he held positions as professor of general surgery and associate dean for medical student programs. He also served as professor and chairman of surgery at the Medical College of Ohio and medical director and MCO at the Cancer Institute there. Dr. Staren is a member of numerous academic organizations, and he is the past president of the American Society of Breast Surgeons, the Rush Surgical Society, and the Toledo Surgical Society. He's a member of the AOA Medical Honor Society and regularly listed in some of the best doctors in America and top cancer doctors as well. He has published nearly 300 scientific works, including more than 150 manuscripts, 80 abstracts, 46 book chapters, and 12 books, while maintaining a practice, being a husband and a father and a friend to many. It's quite impressive, Doctor, and welcome. We are just so excited that you're here at Eisenhower. Thank you for being here. Sitting next to Dr. Staren is Dr. Manasa Vulchi. Dr. Vulchi is board-certified medical oncologist, and she is specifically practicing as a breast medical oncologist. She completed an internal medicine residency as chief resident at MedStar Union in Baltimore, Memorial Hospital in Baltimore, and then completed a fellowship in hematology and oncology at the very prestigious Cleveland Clinic's Tausig Cancer Institute in Cleveland, Ohio. As I said, she's a specialist in breast cancer treatment and sees patients for us at Eisenhower's Lucy Curci Cancer Center in Rancho Mirage, as well as in our La Quinta building, the George and Julia Arduous Health Center in La Quinta. When you speak with Dr. Vulchi, you will hear her say that she believes that every patient is unique and their treatment needs to reflect that uniqueness and her patient's preferences and desires. She understands the importance of open and honest communication, and she's very committed to providing a very supportive environment where patients can come and feel comfortable to bring their concerns and issues. She stays up to date with the latest scientific developments in breast oncology and practices evidence medicine at the highest level of care. Dr. Vulchi actively participates in research and is passionate about, I did not drink before I came tonight, but the words are just sticking. My apologies. She actively participates in research, and she's passionate about making well-designed clinical trials available in our community. Doctor, how many have we opened to date?
We are in the process of opening.
Yeah, pretty amazing. We're very lucky to have. Oh, well, there you go. Testimonial. There's none better. Thank you for that. Sitting next to Dr. Vulchi is Dr. Vasudha Lingareddy. Dr. Lingareddy is board certified in radiation oncology and sees patients at Eisenhower's Lucy Curci Cancer Center. She, again, prepared to be impressed for the third time. She completed an accelerated 6-year pre-medical medical program with 2 years of undergraduate study at Pennsylvania State University, received her doctorate of medicine from Jefferson Medical College in Philadelphia, and then completed her residency and fellowship in radiation oncology at Thomas Jefferson in Philadelphia. She was honored with the American Cancer Society Fellowship Award. That's so dear to me as a 25-year ACS volunteer. Thank you. And the American College of Radiation Oncology Fellowship Award. Prior to joining Eisenhower, Doctor, how long have you been with us now?
5 years.
5 years. Prior to joining us 5 years ago, Dr. Lingareddy was part of the Edward Elmhurst Healthcare in Chicago. She has an expertise in intensity modulated radiation therapy, IMRT, image-guided radiation therapy, IGRT, and extensive experience in stereotactic radiosurgery and stereotactic ablative body radiotherapy. She also performs high-dose brachytherapy for breast and gynecologic cancers. Dr. Lingareddy's radiation oncology practice is almost solely focused at this point on treating breast cancer patients. We are very fortunate to have her indeed. And last but not least, we have Tony Pimentel from Eisenhower's Physical Therapy Department joining us. She's been a physical therapist for 20 years. She holds her doctorate in physical therapy, which she received at the University of Colorado. So yes, she is the 4th doctor sitting in front of you. She's board certified in neurologic clinical specialty and a pelvic floor specialist and expert. We are very lucky to have Tony here, and her commitment, hi, come on in, nice to see you. Her commitment to the health, well-being, and care of all patients. Tonight specifically, she'll speak about breast cancer patients. So, those are our folks. We're very excited, and we're going to get started. And we're going to start with Dr. Staren. I'm going to pull my chair up. Aaron, you let me know if I'm doing the wrong thing the way I move the chair. You know, Dr. Staren, when I was preparing to have this discussion with all of you, and you sent us wonderful, thank you, some really good information, one of the things I was struck by and kind of got hung up on is, where do we start when we're coming to a surgeon? Do we start with a biopsy? Do you do that? Where do we start?
Great question. It turns out that even today, large number of patients will come in because they detected a mass. It is true that increasingly the screening mammograms and those types of evaluations are what identify something as suspicious, and then that patient would go through additional imaging studies to determine whether or not a biopsy was warranted. But as you point out, patients may come in with a breast mass, and they may come directly to the surgeon's office, in which case I will, of course, examine them. But I'll still get imaging studies even before I would do any kind of intervention, both to see exactly what the lesion looks like, as well as look at both breasts to determine if there's anything else going on. When I was a young surgeon, and that was a while ago, but nonetheless, when I was a young surgeon, a large number of patients would get open surgical biopsies. And I remember many circumstances where I'd go into the room and I'd be just delighted to be able to tell the good news that it was benign, but on the other side of the coin, I felt badly because now they had a 2-3 inch incision on their breast that they didn't need because it was benign. Well, over those numbers of years, we've developed techniques that can obtain small amounts of tissue relative to what was done with the open biopsies, but for a pathologist, it's a large amount of tissue. They can still make definitive diagnoses. And these are called core needle biopsies, and they're relatively painless. One of the problems about the open surgical biopsies, in addition to the fact that you'd have an incision on the breast and more scarring in the breast because of the dissection that was necessary, they hurt. It still is more than doing a needle biopsy. With a needle biopsy, they can be relatively painless. You can numb up with local anesthetic, and those can be done usually by image guidance. Again, in the old days, we used to do needle biopsies, and we did fine needle biopsies where we would just get a few cells. Then that advanced to actually taking a sliver of tissue on something that you could palpate. And now the standard is to use some type of an image, either ultrasound or mammographic imaging, to be able to get that piece of tissue from the breast, rarely MRI. Appropriate, some in the room may understand that MRI is used rarely when that's the only imaging study that identifies something, but that's 1 or 2%. But the vast majority of them end up being ultrasound, followed by mammogram, and rarely MRI to guide obtaining a small piece of tissue. So when they come to me, if they've not had imaging, the next thing I would do is to get imaging. I'd work with my colleagues to determine whether or not a biopsy was necessary. If it was, that's generally done by the radiologists. Most of the time, they'll try to do it with an ultrasound to get that sliver of tissue. If it needs mammographic imaging to be able to do the biopsy, that's what will be done. And then we work closely with our pathologist, because then they're able to identify what the pathology is, so that when I do talk to the patient, I'm in a position to be able to give definitive diagnosis as well as recommendations on therapy. And I will tell you, and it's why we're all sitting here right now, is because even when the pathology comes back, immediately we're starting to think, okay, what are some of the characteristics of this tumor? Do I need to involve my colleagues even before I have a surgical discussion, because maybe they warrant that as well? So it's a critical example of how many players are involved in performing optimal care of the patient, given just the simple information of a patient identifying a mass and or something abnormal on a mammogram.
And thank you for that, doctor. And that is when we talk about our healthcare team. And and we really mean that as a healthcare team, because it is a team effort, and you do have a team that's caring for you. I did just want to point out, next Tuesday, which I believe is October 24th, if I have that correct, that date, we do have a presentation with our 4 breast radiologists, and they are going to talk about all of that screening that Dr. Staren just mentioned that's done prior to any kind of treatment, really finding out, it's screening. Do I have breast cancer? And what do we do next? So thank you for that. So, okay, so we're screening. We'll learn about that next week. We've done the screening. Biopsies are done. The referral is made to you as a surgeon. Is there only one type of breast surgery, or there aren't, and how do you decide?
Depends really, again, on the pathology. There are circumstances where something may come back and we're just not sure as to whether or not it's a cancer. And so we probably should start with that, because those are one of the circumstances where we still do open surgical biopsies. Pathologies, one of the ones that falls into the category of fibrocystic, we don't even call it disease anymore because so many people have fibrocystic change that calling it a disease would be like calling blue eyes a disease. So fibrocystic change, one of the types is a ductal hyperplasia, and within that subtype is an atypical ductal hyperplasia. That particular pathology has a chance of upgrading to an in situ cancer, which is malignant cells but without fingers, and in lesser circumstances where it can actually be upgraded on a pathology to an invasive cancer. What I mean by that is that you do the core biopsy, pathology comes back showing this atypical ductal hyperplasia. Because of the knowledge that it can actually be upgraded to something important, that patient will go to the operating room and we'll do an excisional biopsy to get information on that. Based on that pathology, that may be the only surgery needed, and that is an excisional biopsy. There are other pathologies, but let's say, for example, that the patient ends up having an invasive carcinoma, all right? That's the pathology that comes back. Well, we will look at the pathology, and there's a number of different factors that we'll evaluate, and my colleagues can probably go into that in more detail, but suffice to say, we're looking at the aggressiveness of the tumor. We're looking obviously at the mammogram to determine if this is a single lesion, and our goal in all circumstances is to remove the tumor with a margin of normal tissue. That really is the one we can kind of take to the bank. Our goal when we end up getting that diagnosis of an invasive cancer is, can we remove that tissue with a margin of normal tissue?
That's that term, clear margins, that we hear?
Yes, ma'am.
Thank you.
Now, again, when I was a young surgeon, it used to be take 1 centimeter, so 2/5 of an inch margin. Nowadays, negative margins means no tumor on the ink. What they do is the pathology colleagues, again, will take the specimen that is removed and they'll put ink all over the margins, multiple colors. In fact, I often do that in the operating room myself. And then they'll make multiple slices, almost like a slice of bread, and they'll look at those little slices, and if they see tumor abutting the ink, those are positive margins. That means you didn't get the tumor out. Our goal, and it's been looked at many, many studies, is to get negative margins, ink margins. Now, you think to yourself, you go, well, I always heard about cancer being cancer means crabs, they get fingers and roots and all this other kind of stuff. How can it possibly be good that all you're doing is just getting a margin of tissue right at the ink? Well, that's where I depend on my colleagues, all right? Radiation therapy is remarkable in its ability to be able to treat microscopic disease. Chemotherapy and various related treatments can take big tumors and shrink them on down and convert a patient that may have required a larger surgery all the way to a lumpectomy. So directly to answer your question, now we end up having a diagnosis. We've looked at the pathology. We know our goal is to be able to get negative margins. In the past, all patients got mastectomies. That was what was done years ago. Well, I'm very pleased to have grown up in a period of time where that's moved on, and now about 75% of patients could be treated with a lumpectomy, which means removal of the tumor with that margin of normal tissue, but essentially it's a big breast biopsy. And that is shown to be perfectly adequate treatment when done in conjunction with radiation therapy, sometimes systemic therapy as well. There are still about a quarter of the patients that do require a mastectomy. We don't do the mastectomies like we did in the old days, where we used to take the muscle and they were big incisions. I mean, they were pretty deforming, tough operations. Nowadays, when that's done, in most cases, we do what's called a complete or total mastectomy, where we remove the breast tissue. We also used to, in the old days, do big dissections of the lymph nodes. We take all the lymph nodes on out. We don't do that anymore either. We'll do a biopsy of several of the lymph nodes. We inject a radioactive dye, follow that after just a really brief few minutes, 10, 15 minutes, that'll travel up to the armpit, and we can identify that with these little handheld gamma counters where those nodes are and which ones are involved. So the two types of surgery, depending with the goal of getting a margin of tissue, is one, a lumpectomy. Those patients generally will get radiation therapy to treat that microscopic disease that might be around. And they will also get, in most cases, a lymph node biopsy, that sentinel lymph node biopsy I just talked about. The other arm is circumstances where we just can't do a lumpectomy, and those can be very large tumor in a small breast. Sometimes we can try to give chemotherapy to shrink it down, and maybe it doesn't, all right, or not adequately. Those people need a mastectomy. Sometimes patients will end up having diffuse disease in multiple areas in the breast, what we call multicentric disease. Those patients generally are best served with a mastectomy as well. Now, there are lesser circumstances, but those are the major ones. If the patient has a mastectomy, we remove the breast tissue. The patient may still need radiation therapy, and they may still need systemic therapy, but we would also do the sentinel lymph node biopsy in that circumstance to help us know those additional treatments.
Wonderful, thank you. What about, I facilitate our breast cancer information and support group. So we have a lot of conversation that goes on in that group often. And one of the things I hear quite a bit in this group is, well, I want a bilateral mastectomy. If even though I have one healthy, quote unquote, healthy breast, is that okay to do? What about that?
We do bilateral mastectomies. A significant number of bilateral mastectomies are done when patients come in and have bilateral cancers, right? Synchronous cancers occurring at the same time is an unusual circumstance, but it does occur. If a patient is identified of having a breast cancer in one breast, there is somewhere between a 2 and 3% chance that they will have a cancer in the other breast. But even if you do a mastectomy on that breast, or you don't do a mastectomy on that breast, there's no difference in survival. In other words, how long the person lives isn't different. You'd say, well, that doesn't make sense. You know, that percentage that's got cancer, how can that be? Well, because of our close follow-up of those patients, the screening that they now would obtain on a heightened manner, we're identifying the development of that other cancer at an earlier time. And they're getting treated. And the cure rate under those circumstances is way over 90+%. So that's why it's important to have a discussion with the patient and say, if the only reason that you want to have surgery on the other breast is the fact that you have cancer in the opposite breast, these are the statistics. And in fact, the chances of developing a breast cancer on the opposite breast over a period of 10 years is 4%. 4% every 10 years. So again, that's not a ton higher than the general population, depending on what age they were when they developed it. But what about somebody that ends up having a super high risk of breast cancer? They've got 2 or 3 family members that had breast cancer. Maybe they had genetic studies and they may have something that predisposes them to development of breast cancer. And there are other factors, that ADH I talked about, that shows a higher risk of breast cancer. We call high-risk breast cancer that which occurs in an individual that has 20% or higher chance of developing breast cancer in the course of their lifetime. Well, it also depends if somebody is 80 versus if they're 30 when this occurs.
Right.
But under those circumstances, it's perfectly reasonable and appropriate to have a discussion about whether or not the patient should have a contralateral prophylactic mastectomy. And I think part of the reason why that's occurred is the advancements in oncoplastic type surgery that we do, where the aesthetics are remarkable. We now do surgeries where we leave the nipple and the areola in place, so-called nipple-sparing mastectomies. Working closely with our plastic surgeons where they can do immediate reconstruction is such that you have an increase in patient satisfaction related to that type of procedure. And so with the knowledge of somebody having a diagnosis and high risk, I believe, and I think the statistics would bear out the appropriateness of having that discussion.
Thank you. Thank you very much. Thank you. So we do our screenings, find out there's something there. We're referred to our surgeon. Biopsy will be done. It might have to be a surgical biopsy, which is a little more detailed, bigger biopsy. We're not sure. It depends on the tests that are done. Cancer is found. Surgery may or may not happen up front. Next steps, our medical oncologist.
Yeah, I will talk to my medical oncologist even before I do
Thank
that
you.
kind of
That
stuff.
was going to be my next question. Thank you, doctor.
The key to success in taking optimal care of the cancer patient today is communication of the team. I mean, it's, again, when I was a young surgeon, surgeons were the captain of the ship. We kind of did stuff, and then at the end, they would go off to medical oncology and radiation oncology. Those days are gone, and they should be. So depending on the various parameters of that pathology diagnosis that come back, my colleagues may say, Ed, they need this up front. And that's the right way to do it. So,
Thank you. So Dr. Vulchi, our medical oncologist and breast expert, patient shows up to you, sits down and says, so what type of breast cancer do I have? And does it matter?
That's a good question. So we can classify breast cancers in multiple different ways. One way to look at it is, where is it starting in the breast? The most common types we think of are, is it starting in the duct, which carries milk to the nipple, or is it starting in the lobule, which is making milk? These are invasive ductal and invasive lobular cancers. The most common one is invasive ductal, which occurs in about 70 to 80% of women that have breast cancer.
Can't hear you.
Oh, you can. Oh, sorry. So invasive ductal cancers happen in about 70 to 80% of women that have breast cancer, whereas invasive lobulars, they're little less common, about 15 to 20%. And there are multiple other subtypes which are really rare. But a more practical way of looking at the classification is the breast cancer hormone receptor positive? Is it HER2 positive, or is it triple negative? Breast cancer cells have proteins on them called receptors. There are three more common ones: estrogen receptor, progesterone receptor, and HER2 or HER2. If a cancer has estrogen and progesterone receptors on them, but no HER2, they are the hormone-driven breast cancers. They can have HER2 overexpression, and they are the HER2 positive cancers. And some cancers, in about 15% of situations, don't have any of those three receptors, and they're called triple negative breast cancers. It's really important to know which type it is, because treatments are substantially different in each different subtype of breast cancer. So we always look at subtypes before we plan treatments.
I also hear continuously, again in the group that I'm delighted to be part of, nobody in my family had breast cancer. How did I get this breast cancer? I don't understand. Why did I get breast cancer? Is it a large percentage of people that have a familial disposition to breast cancer?
Yeah, so only 5 to 10% of breast cancers are hereditary, meaning they had a gene that was passed down from either parent that put them at higher risk for breast cancer. The rest of the 90% are just sporadic. We know that 1 in 8 women develop breast cancer during their lifetime. and most of those cancers just happen. There are some risk factors that can be associated with a breast cancer diagnosis. Some of them can be, some we can modify and some we cannot. Aging in itself is a risk factor. The median age of diagnosis is 62, so that's something we cannot change. Being a woman is a high risk because the substantial amount of breast cancers are in women. In men, it's about 1%. Postmenopausal weight gain can be a risk factor. Other things, early menarche and late menopause, taking birth control pills for longer than 4 to 5 years, sometimes hormone replacement therapy, having dense breasts can put people at higher risk for breast cancer. So there are a lot of potential risk factors, like alcohol can increase the risk. Even about 3 to 4 alcoholic drinks a week can increase the risk by tenfold. So smoking can cause a moderate risk for breast cancer. So there are multiple risk factors we look at. Some of them we can talk about physical activity, which can reduce the risk. We can talk about weight management in some people if they need it. Alcohol, reduction of alcohol use, smoking cessation, they can all be very helpful in reducing the risk. But we know that 50% of women that have breast cancer, we know that there is a risk factor. In the rest, we actually don't know if they have any risk or they don't have any hereditary causes. It's just sporadic.
The last study that was done that I read also said, you know what, we prefer you don't drink at all. But if you're going to drink, for women it's 4 ounces, no more than 4 ounces a day, for men 6. I have a hard time with that because I'm 6 feet tall and over 200 pounds. I'm built like a guy. You know, what do I listen to and how do I do that? But that really is an important factor.
We typically say limit it to less than 3 drinks a week for women.
Okay. Very important to know. Dr. Vulchi, does what we heard from Dr. Staren, there are people who might get lumpectomy and radiation. Those folks would tend not to be candidates for chemotherapy. But how do you decide who gets chemotherapy? Yeah. And why don't we all get it to make sure that cancer's really gone? You heard the doctor use the term systemic therapy. That's basically the chemotherapy, or can be oral, but chemo because it's for your whole body as opposed to one site in a surgical site or radiation. Yeah. So why don't we all get chemo?
Yeah. So if a person has either triple negative breast cancer or HER2 positive breast cancer, they almost always need chemotherapy. And unless they have a tumor that's under 5 millimeters, they can forego chemo. If a person has estrogen-driven HER2 negative breast cancer, about 70% of them don't need chemotherapy. We do a test called Oncotype, which looks at the genetics of the cancer. And it gives us a number called a recurrence score. And it goes all the way from 0 to 100. And we have trials which show that, and these are well-designed large clinical trials that show that if the recurrence score is under 25, most women do very well without chemotherapy. That doesn't mean that they don't need systemic therapy. They do. Instead of chemotherapy, we give hormone blocker medications. Because these tumors are driven by estrogen, even though a lot of women who develop breast cancer are postmenopausal, they still make estrogen in the body. Instead of the ovaries making them, they make it from adrenal glands and other parts of the body. So we want to give medicines to reduce the estrogen levels so we can reduce the risk of that cancer recurring in the future. So that's how we make decisions.
Could I just add one thing?
Yes, please.
The advantage of a big rear view mirror. When I started, basically the determination on whether or not somebody got chemotherapy was, did they have nodes positive? And so we did these big lymph node dissections and so forth. And as I said, we'd come in and tell somebody benign, but then we'd done a big lymph node dissection and they had the potential complications of lymphedema, pain, etc. I think it's just remarkable what's gone on in breast care over the last 30 years. I mean, it truly is unbelievable. What Dr. Vulchi just told you about was the fact that we're looking at the genetics of a tumor and some of the other characteristics to determine whether or not the person needs systemic therapy, which is not just chemotherapy, it's hormonal therapy, targeted therapy, such as treating that HER2 marker, Herceptin, et cetera. And so to see what's happened is amazing. Now you have patients that may have a really tiny tumor, and they probably would not have gotten chemotherapy in the past because maybe their lymph nodes were negative. But they've got such high-risk markers based on the oncotype or based on these genetics with the tumor that we know they have not just an improvement, but a significant improvement in their chance of cure, of getting to be a nice little old lady, all right, which is the goal, okay, yay, by virtue of those treatments. So it's actually very cool to be able to have seen this evolution to something this remarkable.
Yeah, so we look at the biology of the cancer rather than the size and the lymph node status. We still, if someone has more than 4 lymph nodes involved in the armpit with cancer, we still offer them chemotherapy. But most of our postmenopausal patients, if they have under 3 lymph nodes involved, we still can do oncotype and try to forego chemo if at all possible. That can substantially limit toxicity from the treatment. So.
And I'd like to share with everyone the difference, because sometimes we get confused with the genetics in cancer. So there's something called germline or familial genetics. What do you get from mom, dad, grandma, grandpa? How does it pass down? But in this instance, these are the genetics of the makeup of the cancer cell, and that can drive the treatment. And that was started with when they mapped the human genome and started to realize, well, there are all kinds of different genes here. Dr. Vulchi, thank you. This is wonderful. I heard you talk about premenopausal and postmenopausal, and I know there's some hormonal treatments, and yet we're not supposed to take hormones. So the tamoxifen is a treatment that's been around for a very long time. But in the last 25, 30 years, I guess it is almost, there's this other group of oral medications called aromatase inhibitors. What's the difference and who gets what?
Yeah, so typically tamoxifen works in both premenopausal women and postmenopausal women just based on its mechanism of action. It just goes to the cancer cell and puts a block at the estrogen receptor. So estrogen cannot come and sit on the tumor cell to tell it to grow. Whereas aromatase inhibitors, they block estrogen production from adrenal glands. They don't reduce estrogen production from the ovaries. So if, for example, someone is premenopausal and their ovaries are making estrogen, then those don't tend to work in these women. So one way we look at it is if it's a younger woman, premenopausal, and they have very small tumors, low-risk disease based on oncotype, then we offer tamoxifen. For most of our postmenopausal patients, we offer aromatase inhibitors because we have studies showing that they're better than tamoxifen in preventing a recurrence in the future and improving their cure rate. In premenopausal women, if they have high-risk features, like if they have lymph node involvement or if their oncotype is high, we do want to use aromatase inhibitors. And the way we use them is we suppress their ovarian function, either by surgery or by giving them shots to put their ovaries into a dormant state, and then give the aromatase inhibitor. So there's a lot of nuance that goes into those decisions. But typically, most postmenopausal patients, if they're able to tolerate an aromatase inhibitor, that's our preferred drug.
And there are 3 different types of aromatase,
Correct.
Basically 3 that we are using.
Correct. There are 3 we use, and their risk-benefit profile is pretty similar across all 3 of them. Once in a while, though, we have a patient that does not tolerate one of them for whatever reason. We can then stop that and give them a different aromatase inhibitor, and there is a good chance they can tolerate it. So just because somebody didn't tolerate one medicine doesn't mean we give up on the entire class of them. So we have a lot we can offer in terms of managing that.
Thank you, Doctor. I have one more question for you, and it's something that I call it the myths of breast cancer. And you had emailed me earlier, and I'm so pleased you did, because this is we actually have a whole presentation just on breast cancer myths. Would you speak to a little bit about surrounding it? They're mostly about the risk. Right. If you do this, you're going to get breast cancer. Would you?
Yeah.
Thank you.
So some of the things we commonly hear, if we do a breast biopsy, is that going to spread the cancer more into the rest of the body? No, it does not. Other things, deodorant or antiperspirant use, they don't cause breast cancer. There is some myth surrounding tubal ligations and abortions, and we have data showing that none of them really increase the risk for breast cancer. Yeah.
Thank you. I appreciate that. Thank you, Dr. Vulchi. Hi, Dr. Lingareddy.
Oh, hi.
It's nice to see you. Would you... Radiation for me, you are a real egghead. I'm just telling you, it's all physics, and I get there's IMRT and IGRT, and there's a lot going on in radiation. Does everyone get radiation?
So not everybody gets radiation. I think you all know that. So if a woman chooses mastectomy and she has early stage, her lymph nodes are not involved, the margins are negative, in general, she's done as far as local therapy. There's no radiation. If she has multiple lymph nodes involved, even though she's had a mastectomy, many times we still recommend radiation therapy. But the majority of cases, it's women who choose breast preservation. They're able to have lumpectomy. So they have lumpectomy, sometimes a sentinel lymph node, sometimes not, depending. And those women meet with us to discuss whether radiation therapy is going to be helpful. In the majority of cases, it will be. It will reduce the chance of recurrence within that breast, the affected breast. However, sometimes if the biology, what we've been talking about, the biology is excellent, it seems unaggressive by its genetics, it's small, margins are negative, and our older patients, those that are postmenopausal, and studies have looked at certainly 75 years and older, although I would say our community, that's very young, But yes, and so then we've looked at 70 and older, 65 and older, but really it comes down to not only an individual decision that you personally make, but also a discussion with your radiation oncologist as to what is that estimated risk and how much do we reduce it by, and does it impact survival? Right? It's one thing to reduce the chance of it coming back within the breast, but does that translate to an improved survival? Those are all factors that go into that recommendation.
So, I'm devil's advocate. We all have always heard that radiation causes cancer. Now you're treating me with radiation.
No, I love that.
What happens?
All the studies that look at radiation exposure and causing cancer, generally it is not, we're not talking about the high energy, high enhancing radiation we utilize to treat cancers. That's what we utilize. So is there a risk with therapeutic radiation? Of course, there's risk with chemotherapy, there's risk with radiation, but the risk is very, very small, and it's far outweighed by the benefit of reducing recurrence from radiation therapy. And that's also dependent a little bit on the patient characteristics. Some patients have certain genetic predisposition to develop secondary cancers, and we talk about that. That's not common, but we take that all into account. But in general, no, this is a different form of radiation. It's not like getting too many x-rays or anything of that nature.
Thank you for that. I've heard the term whole breast radiation. What what does that mean?
Also a good question. So we can radiate just the lumpectomy cavity. That's what Ellie had mentioned. I had some experience with breast therapy where you take radiation and you actually put it inside the breast, but you're only treating the cavity where the tumor used to be. So whole breast irradiation is what most women get, where we irradiate the entire breast. If you think about what Dr. Staren said about in the past when we did mastectomies, it was essentially treating the whole breast by removing it. Well, the equivalent is to irradiate the entire breast. So the majority of patients will get whole breast irradiation, but occasionally, sometimes we're just treating the cavity, pretty rare.
And does everyone get the same number? I know radiation's every day, Monday through Friday.
Yes.
Does everyone get the same amount of treatments? I mean, the numbers?
That's also a great question. So the dose that women receive has been studied over decades. So we know what is the appropriate dose to take care of microscopic cells, potential cells. We also know what is the dose if the margins are a little close. You know, like Dr. Staren said, we don't want tumor at the ink, but let's say they're within a millimeter or so, then that dose slightly changes. And if there's a positive margin and somebody refuses a re-excision, or we think it's just focal, and again, another discussion, then that's a different dose. But in general, most women will receive 3 weeks to the whole breast, and then maybe 3 to 5 treatments where the tumor used to be. That's what we call the boost. So it used to be, if any of you have gone through radiation years ago, we used to give 5 to 7 weeks of radiation therapy every day. And we found out that through studies, large randomized Europe, Canada, US, that we can give less radiation, but give a higher dose each day and give it safely, so that the cosmetic result, the breast tissue, does the same and reduce the number of treatments. So very few women are not offered accelerated radiation or the standard 5 weeks. Sometimes that still happens, but the majority of women will get this, what we call accelerated hypofractionated radiation. So typically around 3 weeks, plus or minus a week.
And so you use the term cosmetic results. What about breast reconstruction? Should breast reconstruction happen before we have radiation, after we have radiation? Where does that fall?
Also a good question. We, as radiation oncologists, we always prefer after, but that's not always possible. That's not always emotionally what's best. And so that's another discussion. We always discuss with the reconstructive surgeon timing, sometimes expander. If it's a mastectomy, sometimes expanders are placed, they're partially expanded, fully expanded. There's so many variations. But we find that cosmetically women do better if they delay reconstruction, meaning they have the mastectomy, they go through all their radiation treatments, they heal, then have reconstruction, or they do immediate, where they do everything all at once, but we have to be very careful about delaying treatment. You know, if you have a complication related to the reconstruction, but again, that's an individual discussion. Is chemotherapy involved? It's really a lot of physicians working together. So the answer is ideally after. Certainly the permanent implants, that sort of thing happens after. But, you know, definitely we work with even at the time of surgery, having some reconstruction done.
Thanks, Dr. Lingareddy. Thank you. Hi, Tony. I see you down there. Hi. So, Tony, what does a physical therapist do for breast cancer patients? Share with us your role on this team.
All right. Thank you for inviting me here. I'm excited to be here. So actually here at Eisenhower Health, we have a rehabilitation team. So it is not just physical therapist, but also occupational therapist. So for occupational therapists, they manage and care for lymphedema. So for patients who have swelling, pain in the arm, they go to occupational therapist, and then wherein they get assessment of the scarring, of how the skin is looking like, and they get manual lymphatic drainage, and then they get some compressive garment as needed, definitely exercises, and patient education. And then for us, physical therapists, we do a lot of things. So first, for shoulder pain, for shoulder range of motion, we make sure that they have that range. Yes, strengthening. So we take care of them by doing some exercises, some joint mobilization, and of course, patient education, energy conservation techniques. And then we also do some chemotherapy-induced peripheral neuropathy. This is common in our practice, wherein we see a lot of patients wherein they have difficulty with balancing, with difficulty walking, frequent falls. So we take care of their balancing, we take care of their walking. Also, for hands, for their dexterity. So we also give them some exercises, some strengthening, some tips so that they could avoid some lack of sensation. I also take care of deconditioning. We know it's a fact that after this cancer treatments, the number one symptom is cancer-related fatigue. So once we have that, there would be lack of motivation, increased anxiety, stress, and weakness and pain. And this goes and on, and it would result to deconditioning. So as a physical therapist, of course, following the evidence-based practice, we have this exercise regimen that we would design and they would follow. And then as being a pelvic floor therapist, and I was listening to, I have my notes too, doctors, listening to the doctors we know that chemotherapy would, and other treatments decrease the estrogen level. Thus, women will have some pelvic floor dysfunction. So those are the things that we offer.
Okay, thank you for
Yes.
that. Can you, I just wanted to share, Dr. Vulchi, jump in here. There are some chemotherapies, systemic treatments, when Tony was talking that, when she was saying about physical therapy and fingers and toes cause like numbness or what we call a neuropathy. Is that what we were referring to?
Yes, correct.
Okay. It tends not to be permanent. It can hopefully, and
It depends on the situation. Most of the times, we follow these patients very closely while they're on treatment. So if they're starting to develop or showing early signs of neuropathy, we can make changes, dose adjust, help them out. We even try to prevent it by asking them to wear cold gloves and cold booties while they're getting certain types of chemotherapy if we think they're at high risk for neuropathy. But we do want to identify early so we can prevent it from being a permanent issue. But some women end up having permanent neuropathy, unfortunately, from treatments. So that's when physical therapy really can help.
If I may say.
Tony, please.
So it's nice to know that there are some things that we can do to prevent. However, in our case, we see the patients towards the end, wherein it's already, they're done with chemotherapy, they're done with their radiation, and then they cannot walk because of the numbness, tingling, or they've been having some burning in their hands. So I'm having a shameless plug, if you...
It's not radiation, though.
No. So we would really love to have a prehab to see patients at the very beginning, so that we can evaluate, assess their the signs and symptoms, how to prevent it. Are they susceptible? What should they do? What triggers? Thank you.
You're welcome.
That's fantastic. I've actually sent them a few of my patients who hugely benefited. So that's a good, yeah.
And I do want to point out that if you saw us whispering over here, we were, that the vast majority of patients do not develop neuropathy from chemotherapy. This is a very small subset. I don't want people to walk away thinking
and
they
there
do.
are very few chemotherapy regimens we worry about.
Right.
We talk to the patients ahead of time if we are planning on that treatment. Yep.
And
I'll make a plug
Please.
as well. I don't think we've always had pelvic floor therapy. At least it started soon after I started here, and that's been extremely helpful for incontinence, both male and female.
Thank you, yes.
We've heard, just had tremendous success with you guys.
Thank you.
Thank you.
Yes,
It's a wonderful program. It truly is. Thank you. So when I'm listening to you, Tony, what I was thinking was, well, can we have physical therapy or occupational therapy while we're getting chemo and while we're getting radiation to kind of help lessen some of these side effects? Is there any reason we couldn't, I guess is what I'm asking.
Okay, there's my short version of answer is yes. The long version is it depends. It depends on our doctors, their protocol. Of course, we follow the important things, their current medical status, their post-surgical healing. So it really depends on that. And I always encourage my patients, cancer patients, to have a talk with their doctor, because there's a lot of things that the doctors are already taking care of. Be an advocate for yourself. Ask, will I benefit from physical therapy or will I benefit from occupational therapy? And I'm sure they're very much willing to do that. My other answer for that is yes, they can do while doing chemo, while doing radiation. For chemo, we know that the side effects would be very tired, lack of energy, lack of motivation, increased stress, and increased anxiety. Guess what? Exercise. Exercise will really boost up everything. But of course, you might say, I could hardly stand up, I could hardly walk, you're making me exercise? Well, yes, we physical therapists, occupational therapists are very skillful, creative, manipulative, to make you do something. Like for me, for example, I practice a lot of different kinds of breathing for relaxation, breathing for energy, and I also teach Tai Chi. There's a good study, 2021 study, wherein Tai Chi is a good preventer of fall. So yes, they can do that while doing chemotherapy, going to radiation therapy. For radiation, they need to have their arm like this.
Yes.
Correct?
Correct.
So having that, this or this, they need a lot of range of motion in the shoulder and in the trunk. And then they need to maintain it. How can they do it? They're in pain. They will not do it. So I've gotten some referral from our radiation, for our oncologists, wherein they say, help us with the range of motion, help us with the pain. So yes, we do our gentle manual treatment and some exercises and advice on energy and joint conservation techniques, how to do that. Yes, so we've been successful with chemo and radiation.
We send them to you immediately, but remember, we sometimes use radiation to treat lymph nodes if the lymph nodes are involved. So even though Dr. Staren may have only taken out 1, 2, or 3 lymph nodes, I'm irradiating the remainder of the draining lymph nodes. That definitely stresses the body. So usually we send them initially right away to you for lymphatic massage and range of motion. The only time, and you guys have been great about contacting us, is if the skin reaction starts, right? Then it becomes, or has become more severe. Then it becomes an issue of, should we be manipulating the tissue? So there's always communication there. That's fantastic.
And definitely we know that once it becomes so sensitive, fragile, we stop for a while. And don't forget, physical therapies on the other end, wherein we can still do some exercises, some gentle mobility, not in the area being irradiated, but on the other area. So I love this collaboration.
I did want to just mention, since Dr. Lingareddy talked about radiation to the axilla, that, again, that's relatively new. And there's
What's the axilla?
The armpit.
Thank you.
Okay.
Just thought I'd jump in there.
You know what? My side of the family was all business. My wife's side of the family, everybody was in healthcare. I mean, everybody, doctor, nurse, et cetera. And so there, it's all healthcare terms. And then I go back to my family, and they're like, anyway, radiation to the armpit has really shown a remarkable ability to be able to treat nodes in that area. And it's game-changing in that it does have lesser incidence of lymphedema. You don't have an incision there. The incidence of difficulty with movement is less. So when you have a surgeon expounding on the value of radiation for a procedure that we routinely do, it's really something to note. And I think we're going to see more and more patients that have nodal involvement getting radiation therapy rather than going to completion axillary dissection, and that's appropriate.
Yes.
And I do want to point out at Lucy Curci Cancer Center, we do offer stress management classes, exercise classes, Tai Chi, and everything like that with folks trained. Matter of fact, our exercise person comes out of your department from occupational therapy. Very important. Well,
They don't do that Reach for Recovery anymore.
the American Cancer Society's Reach for Recovery program, for those of you who don't know, is for women post-mastectomy. They would, and many years ago, women would have mastectomies and stay in the hospital. And then for a while you heard, oh, they have drive-through mastectomies. That's a terrible thing. No, what was happening was the surgical techniques of these brilliant hands changed, got better, different, got to the point where most patients, barring any medical complications, doctor, don't necessarily have to stay overnight. So the Reach to Recovery volunteers, there was no one to visit in the hospital. Reach to Recovery is still at the American Cancer Society, but it is online.
Pretty much all patients having a lumpectomy go home that same day, and even the majority of patients having mastectomy go home on that day.
Yeah.
And frankly, who wants to be around sick people?
Yeah, you want to go home.
They do want to go home, and so we're very attentive to making sure that they have home services and knowledge of the type of care that they need. There are circumstances, patients perhaps having bilateral reconstruction in conjunction with bilateral mastectomies. That might be pushing it a little bit. And some of it we're learning as we go along, but those patients may be in for one, rarely 2 nights, but the majority go home the same day.
And we are very proud also, we do have a post-mastectomy program for our surgery patients that are seen by Eisenhower surgeons. They are given a gift basket with appropriate cover afterwards so that you're not lifting your arms to put something over your head, that you have drains in after surgery. There's a pouch you can put your drains in once you can shower. So lots of good support that we're really very proud of. So let me jump in for a moment here. We cannot give and do not give medical advice specific to anyone's personal treatment. In a very generalized way, if you wanted to mention the medication, and we could have a generalized discussion, but we can't be specific.
Yes. So most women don't get all those side effects. Common things we see, if it's an aromatase inhibitor, we do see fatigue, but nothing debilitating. And again, exercise can be really helpful in managing that. About 30% of the women can have joint aches and pains. Again, it's not joint damage, it's not arthritis, it's achiness and stiffness. Again, gets better with exercise and movement. And yoga and Tai Chi actually have a lot of data showing they can help with that. Some people can have hot flashes, like menopause again, for a short period of time, but tends to get better. Occasionally, we do see mood changes. Most of the times, they do improve, but once in a while, we have to change to a different agent. Again, that's very, very rare. But most people do extremely well on these medicines. That potentially can happen, right? Yeah, just like with menopause, we gain weight. It's taking that estrogen level to even lower levels, so it can. Again, exercise can be really helpful, and managing your lifestyle, dietary changes, and trying to prevent a weight gain. Because again, we know that gaining weight can put people at higher risk for recurrence, so we want to be really conscious about that. But it's the weight gain associated with these is not, you won't gain like 30 pounds in a couple, it's like 1 to 2 pounds kind of, it's minimal.
My friend told me she gained 100.
What happens is it's such a good excuse, and I do encourage, for those of you who haven't joined us in our breast information and support group, and notice what we call it, a breast information and support group, because that's really true. And come and meet those other experts besides these experts, the patients who've been there, gone through it. We have wonderful things to share. Everyone is welcome, doesn't matter where you're treated. You're welcome. We meet every Wednesday in the morning at 9:30 at Lucy Curchi. You don't have to register and sign up. You can show up, or if you want to know more about it, Cheryl's our expert. She's here and is happy to share with you. It's a great place to come and hear. How did you do on that medication? What did you do? Oh, okay. Come and join us. We would love to have you. Please. The Tai Chi is at Lucy Curchi. Again, Cheryl's happy to explain. You do need a physician referral to exercise. Hi.
No.
Good question.
Yeah, that's a good question. So the there are multiple different types of genetic testing. One is checking if there is a hereditary mutation that's passed down from your family. That's germline testing. Whereas NGS is, we typically use that for people who have metastatic cancer, and we analyze the genes in the cancer itself to see if there are mutations that we can target with medications. So there are certain mutations like ESR1 or NTRK that have specific medicines, and if a person has those mutations, we can use those medicines in them. The other genetics I talked about is the oncotype or mammaprint. Those are genetics that we check in cancers that are curable, and we check to see if they need chemotherapy or not. So different types.
So Dr. Vulchi, I think what we're referring to here is we're learning more and more as we see the genetic makeup of a tumor. A lung cancer genetic makeup tumor might be similar as a breast, and we could use the same drugs, and whether it was lung or breast.
Yeah, so certain mutations can happen across tumor subtypes. For example, certain types of lung cancers also express HER2 or HER2. Certain colon cancers express it. So we kind of use the same drugs to help those specific mutations.
Well, now you all know why I don't retire. How fortunate are we to have a team like this, and how lucky I am to work with all of you. Thank you. After very long and busy days, all of you, thank you so very much for a wonderful, wonderful discussion. Thank you.